And we have started the recording on the Wednesday, December 20th, Public Safety Committee meeting. It is 12:35. We're going to go from now, scheduled to start at 12:30 till about 2. Some of you have been here for a little bit. I apologize if it was announced as noon. If that was so, let us know how, and we'll fix it for next time. Maybe some of you are just early. And this whole meeting is on opiate and heroin recovery options, learning more about it. So there's a mix of knowledge on the assembly. I found out some people very familiar with this issue. I'm relatively or even completely ignorant on it, and so I'll ask a lot of dumb questions, I'm sure, but we'll provide ample opportunity for your much more informed questions. And I plan on dedicating this entire meeting to it. I think, and there's a lot of evidence to suggest, that it is one of the huge contributors to what we've been seeing in public safety over the last couple of years. And we'll get to some of those data points again. Melinda Freeman of DHHS presented on that before, but there's just, in terms of needle usage, in terms of heroin seized, in terms of deaths from heroin, those have all gone dramatically up. We don't know how many people are using heroin in our town, but all three of those indicators going up at the same time gives us some indication that we have a serious growing problem. Today's focus is on recovery options, and I'm going to partially turn it over to Melinda. She's been fabulous on this. She and I went around and looked at Ron's clinic and others. She knows she has still a lot more work to do on educating me. But she helped arrange, really did arrange, but we coordinated on it, 3 presentations today. And maybe I could just ask you to tell the committee a little bit about those presentations.
Sure. Do the roll.
We should. I apologize. He's right. So roll call, Mr. Weddleton.
John Weddleton. Christopher Constant.
Eric Croft.
D. Trainee.
Pete Peterson.
Forrest Dunbar.
Tim Steele.
Fred Dyson.
Suzanne LaFrance.
Dean Gates, Assembly Council.
We typically just do the head table. Anyone dying to be introduced on the record out there, introduce themselves? So thank you, Mr. Constant.
Before we move on, just a quick question on the timing as well. My calendar says we have another meeting this afternoon.
We do.
And at 2.
Yes.
And my notice says that this meeting ends at 1:30.
Okay. No, we had noticed it as 12:30 to 2.
This one ends at 2. The other one starts at 2.
Okay, my notice just says till 1:30. It's going to be
12:30. We're going till 2.
Thank you.
Melinda.
Okay, great. Thank you. Again, I'm Melinda Freeman. I'm the Director of the Department of Health and Human Services. And I want to thank our guest presenters today. Also our guests, we have Petra Davis here from the Alaska Needs Assistance Association, as they are actively involved in the opiate and heroin response process, I'll call that. So I have invited speakers here today to talk with you about 2 primary areas. One is the services that are currently being provided in Anchorage in response to opiate and heroin addiction. It's a very complicated process responding to our community needs, so I've asked our guest speakers to speak on that. And then there are several people who are willing to talk about their own recovery from opiate or heroin addiction. And some of those cross over. Some folks are working in the field as well as being in recovery. So I want to thank our guest presenters today. And our first group of presenters are from the Ernie Turner Center. So if you want to come on up. And they have a structured presentation. Apparently it's 3 minutes each. And of course we want to allow assembly members time for questions. So thank you again. If you just come on over, and I think we have enough seats, and introduce yourself as you do your presentation, and we'll go from there. So thank you again for coming today.
So, hi, my name is Sasha Sardis. I'm just going to speak real quick to say that we're from Cook Inlet Tribal Council, and Ernie Turner Center is a part of Cook Inlet Tribal Council. And I will give a quick overview of the services that we provide, and then each of us will kind of go into a little more detail on the specific service. So Cook Inlet Tribal Council Recovery Services, we have an assessment program, we have pre-treatment, outpatient, intensive outpatient, a 3.5 residential facility, and then we also have a recovery and reentry facility.
3.5 beds, you mean, or?
I'm sorry, level 3.5.
Level 3.5, sorry.
Residential facility. So that is for co-occurring dual diagnosis. It has 15 hours of work therapy with 20 hours of clinical services, 24-hour structured 7-day-a-week facility. Peer support services. We also provide prevention. That is to the youth right now. And then within Cook Inlet Tribal Council as a whole, we're kind of like a Walmart, a one-stop shop. We have employment training services, family services, which provides healthy relationships, and parenting classes. They work very closely with OCS. There are some equal workers that are in there as well. We also have TVR, which is Tribal Vocational Rehabilitation. We have our third floor also offers TANF for different housing, payment for different housing. We also have a daycare facility, and then we have a youth employment department as well. It's called EAST, and they have after-school training programs. So we have a lot that are available within our services. And then I will pass it over to Venus to kind of talk about the recovery and reentry portion.
Hi everyone, my name is Venus Woods. I'm the reentry manager for recovery services. Thank you. I'm also a person in long-term recovery, and I also am a 2-time felon. I got out of prison in 2009, and I started working in this field. I ran a mentoring program in 2010 and 11, and I've just kind of climbed up from there. So part of Cook Inlet Tribal Council's reentry program is we have it's a very unique program called Shanlut, and it's CHANLYUT. And it is a structured work-based program with a treatment component. The level of care is intensive outpatient, so the clinical services are different than the residential, but they live there and they get work training. So we have a couple different social enterprises that these gentlemen run. So they learn everything from maintenance, janitorial. We have a wholesale, it's called wholesale, but basically it's kind of a catering. They make food and we sell them to places in the community. And so they learn these work skills there. They get the treatment. It's an 8 to 16 month program. And then we also have a supportive housing side to that. So they can do the program side, and then they can stay after they graduate the program side, they can stay on the supportive housing side. And we work with them on that side just on different things, like finding permanent housing, finding a job, things like that. We also do some work in the prisons, Goose Creek and Highlands specifically right now, where we're working with prisoners pre-release. We also do some work with the Anchorage Wellness Courts and the Federal Hope Court.
Treatment for specifically heroin or a range of drug and alcohol?
A range of everything, but we are seeing a lot of heroin. A lot of pills.
There are differences between, it's you, Mr. Trainee, so different approaches depending on the different drug involved?
I wouldn't necessarily say different approaches.
So our programs are manuals. We have manuals for all of our programs and program expectations. They include so many hours of clinical services, that's education and therapy groups, and then so many hours of work therapy. When it comes to the individual in the program, their treatment plans are individualized to them and what their needs are. So there's not a very black and white answer to that, but I can tell you that our program requirements and our schedules remain the same, but the actual treatment plan for the individual is individualized for that person.
Mr. Trainee, and then
There's many kids are getting opiates in the high schools because how young do you deal with kids?
So our services are for 18 and over as far as our substance use facilities go, our assessments, but we do have a prevention team. And our prevention team approaches youth ages 14 to 24. They are in some schools right now. I don't want to speak too much on that because I don't know the exact, so I don't want to say something that isn't accurate. But they are in some schools where they provide some cultural arts and crafts groups. We have an individual who is in the Valley and provides services in the Valley in certain schools. And then we have a team of 2 that are out here in Anchorage who are also in some of the schools, some of the after-school programs, and different things like that.
Thank you.
Also with a partnership with the FBI, the DEA, and the U.S. Attorney's Office, I and our peer support have done some panels to the high school. So we've been available to the students to talk a little bit about what we see professionally and then also share our personal experiences. And that's gone pretty well.
The reason I ask is some of these kids are getting involved in this so young. We're talking 14, 15, 16. By the time they're 18, they're already addicted to it. Thank you.
Mr. Steele?
Yeah, my question goes more to success rate. How long do people usually stay? Can they come back in for another shot of emotional support, what kind of success rate do you have, if you have any figures on that? And how do you define success?
That is what it is. That was something that I had in my presentation, which is on my phone. So if you see me on my phone, it's because I'm reading what I'm going to say to you guys. So definition of success is different for everybody. I think for us, our definition of success is harm reduction. We have some participants and family members. We call our participants family members because we have a very home family feel to it. I mean, they could come back 15 times, they could come back 5 times, or they could be there 1 time. We also have a great alumni program that really reaches out to everybody who has been through our services to kind of keep them involved, right? We have some individuals who, for recovery and reentry, who have gone back into the system, but maybe they only went into the system twice instead of 5 times that year, right? Or maybe it's only for misdemeanors and not felonies. Now, that to us is a success.
Do they usually voluntarily come back into the program, or is it usually they get busted somewhere and they come back in?
It's both.
It's both,
It's definitely both.
Mr. Constant?
Thanks, Venus. Yeah, good to see you.
Yeah.
Now, you mentioned reentry in Charlotte, but is the Justice Center still part of that operation?
So I don't work for the Alaska Native Justice Center anymore, but they still have a really strong reentry program. It's separate from the work that I do with CITC, but we do work together on a lot of communities type stuff.
Yeah, because they're a primary reentry focus as well, right?
Yes.
So that's another one we might want to hear from at some
Yes.
point. So thank you.
You guys can't talk jargon to each other
Well,
without letting me in.
I'm just saying, Alaska Native Justice Center is a key
That's
to
where I
this
started
system.
out working.
Yeah.
And so are all reentry coming out of prison or coming out, what does reentry mean?
Well, to me, reentry means someone coming out of prison, reintegrating back into the community.
Mr. Dyson?
Yeah, maybe Mr. Chairman, I was hoping that we could certainly learn about providers and how they do it, but I'm wanting to know how the opiates affect a person chemically, and their behavior, their cognitive ability, and at what point does it start? I mean, we define alcoholic often as when it starts messing up their life, their job, their relationships, and then when it's out of control, the person is no longer able to manage their own life. And then kind of how the treatment works, and do you need to get the person completely clean for some period of time before they can even start thinking about behavior mod and cognitive skills and so on and so forth. So is that outside of what you want to accomplish in this meeting?
No, it's a mix of those two. I want to hear about providers and what's out there, and I'd like to hear from family members, not patients. you said participants. Anyway,
And we have,
so we have a mix of both of those.
Yeah.
Yeah, and that misses what I'm talking about.
Oh.
And we're gonna hear testimonies, you know, how it's worked for them and so on and so forth, but, yeah. So
Well, what's the part I'm missing then? What?
I wanna know what it does physically and emotionally and and where nerves
I think they're
and so on. And then, how does a person get healed or released from the chemical dependence? And then what has to go on to, mentally and emotionally to get out of the grips of the monster?
So you guys heard that to the extent you can do it too. I know Ron can do some of that. So yes, all three of those things. And to the extent we miss it in this meeting, let's have a conversation at the end of it to what we do as it comes going, because this is going to take more than one. But we'll try and hit all those things, I think.
Yeah, and I know a couple of physicians who have been treating this, that's what they do, you know, and so on. But maybe the rest of us don't need to go as far as I'm interested in, but it seems to me we need to know some of that.
No, I think you're right, and I'd like to. Mr. Dunbar and then Mr. Peterson, then we'll let you guys get back on track.
Yeah, so I have kind of the opposite questions from Mr. Dyson. That is to say, I'm interested in the broader policy questions, and to the degree you're able to answer them, I'd first like to ask you what your funding sources are. CITC has always been a little bit of a mystery to me. Like I understand what CIRI is, I understand what some of the other providers are, but CITC I'm always a little bit confused by. Is it a mix of federal and state and private dollars, and if so, can you break that down for me a little bit? And then the second question I have is, what, in your opinion, are the most effective policy interventions that we could do to combat the opioid crisis?
You guys can see we're going to be all over the map, from individual stories to medical technique to funding sources. We're trying to get our hands around a big issue.
It's a big subject.
So
it is a huge, I think maybe if we could continue on with our presentations, we're going to approach some of these questions with
Great.
some answers.
let's do that, and then we'll wrap back around to the extent that we want. Is that all right, Mr. Dunbar?
That's fine.
Yeah. Yeah, go ahead then. Excellent.
So I'll just finish up just a few things that came to mind when I thought about, reentry in our community, and what's needed was lack of treatment, lack of money for housing, removing the stigma associated with being a drug addict or a felon. Those were the top things that came to my mind. And for my program, we are funded through state, very little state, federal, Medicaid, and Indian Health Services.
Which are both federal. So, I'm sorry to interrupt, but would you say like the majority of your funding comes from the federal government in some way, whether Medicaid or some other kind of grant?
I don't know if we can accurately answer that because we're not on the billing side of things, we're on the services side.
Melinda?
I think it's important to note that, as you said, there are multiple funding streams into a program like CITC, depending on the actual program module. When Venus is talking about Sean Lute, they generate program income as well from these social enterprises. The last time I checked, it was a moving company.
We did have one. We closed that one.
Okay,
But
how about landscaping?
we do landscaping. We have
Snow
maintenance
clearing?
contracts with Credit Union One and a couple other different places. We do snow removal, the wholesale, the catering. We do that with like Providence and Alaska Club, and so we
the
do generate money through that.
program income, billing private insurance for some of the services, as well as dwindling state dollars from Division of Behavioral Health, and then the Medicaid billing for Medicaid.
Yeah. We couldn't really tell you which one brings in the most, and then of course IHS is huge.
Yeah.
We'll work on that and circle back around to it. Back to your presentation, Associated Venus.
Hi, my name is Wesley Brewington. I'm the Peer Support Supervisor in Recovery Services Department at CITC. I'm also a person in long-term recovery, which means I haven't had a drug, any mind-altering substance since February 6, 2013. Coming up on 5 years clean. Opiates and other drugs and alcohol, just that lifestyle destroyed my life. I did 14 months at Nugent's Ranch. I did 2 years incarcerated. And now I'm on the other side. I supervise a team of peer support specialists who are all in recovery. If you're not familiar with what a peer support specialist is, A peer support specialist brings the lived experience of recovery combined with training and supervision to assist others in initiating and maintaining recovery, helping to enhance the quality of personal and family life in long-term recovery. So me giving hope to the guys and the females in our residential treatment centers, just to show them, like, with experience, strength, and hope, that we can and we do recover. And research shows that people connect easier to lived experience. I bridge the gap between, well, me and my team bridges the gap between the clinical counselor or mental health clinician and the participant. So there's some things that a participant would talk to me about because they feel I understand it. It was really big for me in early recovery that somebody I talked to could relate to me and what I had going on, because somebody that couldn't relate, I just wasn't really comfortable talking to them. So sometimes I talk to participants and they tell me things like, you know, Wes, if you wasn't here, my counselor doesn't understand me. Like, I feel like I could talk to you, I could relate to you, and he tells me things that I could help him work through that he wouldn't necessarily tell his clinician. So, and we also have data that shows peer support improves relationships with treatment providers, increases treatment retention, improves access to social supports. I support all roads to recovery. I got sober in AA. Even though my main problem was drugs, I still latched on to AA and had a sponsor, but I support all roads to recovery. So what that looks like for our participants is, you know, what worked for me may not work for you, but let's find out what works for you, and let me walk beside you, not do the work for you, but walk beside you and help you find that path to your recovery so you can gain your life back, rebuild those bridges with your family, have a job, and become a productive member of society, as I did. So I think some of the barriers we face at a state level are a lack of resources just across the continuum, and I think we can all agree to that. Peer support accreditation, which is being kind of worked on now, is to have peer support be certified peer support specialist, and be able to bill for that. Equalizing pay, and just eliminating the stigma of people in recovery working in providing direct services. And also barrier crimes in the variance process is something I run into when hiring peer support specialists, and they're good. You know, they're good, and like, we need them on the team, but it's hard to get past barrier crimes. I have two lifetime barrier crimes, and I had to get a variance for, and it's just that hold up in that process of trying to make that happen. And sometimes, like, we can't get them on our insurance because they have a driving suspended license, and you know, we have shared lived experience, but we made it out of that, and that's always a barrier for us.
Mr. Chairman?
Yeah, let him finish, but then you can go.
And then just the last thing, like, areas we feel should be improved at the state level for peer support are more sources, including detox, youth prevention programs. I also believe that, you know, if we get them where they're young, we don't have to, you know, be a less influx of people coming in later in life. Just more sources across the continuum, such as a recovery community organization, also known as a RCO, which would increase social connectedness, and just harm reduction programs, I feel. And I'm open for questions.
Did you want to stay in the queue or come back around?
So let's see what Fred's got.
Mr. Dyson? Yeah.
So, very interested in what you said about barrier crimes, and I think that that's jobs you can't get because of your stuff on in your record.
Yes.
And my perception is on a state and city level that some of those are pretty ridiculous. That the job you can't grade has no logical connection to the crime. Yes?
Yes. Yeah.
So,
Absolutely.
if you could offline tell me about some of those. I'm trying to get this mayor to get after it, and the judicial reform guys are trying to get to it too. But I understand. I understand there's some 400 jobs on the state law you can't get.
Yes.
Okay.
It's really difficult.
Help me out, because I want to help on that problem.
Is that federal, state, or us that restricts it?
I know the state and municipal.
Yes.
are the significant problem.
Yeah.
Feds do too on some stuff. Like, for example, if you have a federal drug crime, correct me if I'm wrong, but I don't think you can work in a facility that receives certain kind of Medicaid funding. Is that it? You can't work in the medical field if you have a drug felony, and that's a federal requirement.
Yeah. So as me having a lifetime barrier crime, I'm pretty transparent. I have a robbery. and it's a lifetime barrier crime. Also, I have a burglary, which is a lifetime barrier crime. So that says I can't work with kids, I can't work in state, I couldn't work in this building, and I couldn't work for where I'm working at now without a variance. So once I get, so to put in a variance, we have our own legal team at CITC who puts together a variance, which is very extensive and it's a lot of paperwork. All my treatment certifications, a letter, credible people writing me reference letters, and it's just, and then it's up to them if they grant it or not. So
And take that one, Wesley. Is that a state, local, or federal restriction? That lifetime variance?
the life is for it's state.
State.
Yeah.
And in lifetime, as obviously I
Yeah.
wanted to confirm it, you can't say that was 20 years ago. It
Yeah.
doesn't matter.
It doesn't matter. It's
Who
lifetime.
do you appeal?
So
Well-
different crimes have different lengths, right? You could have, if you have, some have 7 years, some have, and some are lifetime.
Right.
Some
Who grants that variance?
the Department of Behavioral Health. Department of Behavioral Health.
The state?
Mm-hmm.
Yes.
So it sounds like it's a mix. Us a little, feds a little, lot of state though. Okay.
And you can imagine how many are going through right now, especially with
Sure.
the rise in peer support. And it's just 2 people who are approving them for the state.
Mr. Peterson.
Thank you, Mr. Chairman. And so, there was a story on the news here a month or so ago where a guard got busted trying to bring heroin in. Was that Highland Mountain or
Creek, I think.
Goose Creek? Maybe it was. Is that a problem? Do we have people that go into jail and become more addicted in jail than they were outside?
I can kind of speak to that because I was incarcerated for 2 years. I think there's more drugs in jail than there is on the streets, and it is easier to find it. It's the halfway houses too, yeah, and it's more expensive, but there's more drugs in jail than there is on the streets.
Yeah, that's what I'd heard too.
Mhm.
Thank you.
And it's a huge problem for DOC to correct it.
Mr. Constant?
Yeah, I think the gist of what I heard you say there, DBH is restricting the jobs you can take because they're a funder to the program, and that's kind of the link between these, and you hit it right on the head, the feds and their restrictions relative to jobs that are funded by feds, and so that's a way we can get to that question in a meaningful way. It's not just, you're not generally restricted from working in jobs because you have these crimes, you're restricted from working in jobs in certain environments because of the rules.
Right.
Yeah, one of those I remember when, so actually, formerly Senator Dyson and I did work on this years ago because there was a very large difference between a drug felony and a drug misdemeanor in terms of the variety of jobs you suddenly couldn't do. And I remember working with the elderly in senior care facilities. That was another place where they were generally restricted. So.
It's a moment where, obviously, at the municipal level, we can do it ourselves. The state, I think, is amenable to it, and federal waivers, it's a time of flux at the federal. So I think the conditions are set. We might be able to get a lot of those restrictions by doing it or asking to do it. So that helps us a lot. Sasha, back to you, and then we'll interrupt you soon.
Yeah. Perfect. So again, my name is Sasha Cernis. I am the treatment program manager for Cook Inlet Tribal Council Recovery Services. I too am a person in long-term recovery. I've been clean since 10/11 of 07, and I come from a family of addicts. So my parents were heroin addicts. I was born a heroin addict, and my brother was born a methadone baby. So I come from a line of that. My father is now in the field. He actually works at Sean Loot, and my brother is also in the field, and he works at Cliff Row. I went through addiction and in recovery, and my brother didn't. But both my parents are heroin addicts, so you never know who it's going to affect or how it's going to affect them. I can tell you that my brother does have, and I can make an amends to him for this later, because now you all know my name and his last name, but he does have a lot of behaviors of an addict that he doesn't use, right? So it kind of goes back to how do you address the behaviors and where do you address it? I can tell you for our facilities, right, I could speak on, we do substance use, and we also do a little bit of co-occurring. So we have in our residential, outpatient, and re-entry facility, each individual who comes through there is provided a substance use counselor. And our substance use counselors are certified in their counselor and chemical dependencies, which they get through RADAC. Some of them have schooling, they have their bachelor's or their associates in either social work or human services, or they just have the certification, and the majority of them have lived experience. We also have a couple counselors who are alumni of our residential facility.
And Sasha, I want to make sure there's time. Are the people next to you presenting?
They are.
Okay.
Yes. How much time do I have?
Well, we have 3 different presentations. You've got more people, and we're done at 2, so we should get to them. I didn't mean to. Well, I guess I kind of meant to cut you off, but
That's
I apologize
okay. You guys
for
will
it.
just have to call us back
Okay.
so that we can talk
Okay.
in more detail about this. Is all it is.
Tell me before you turn to them. The flip side of what Wesley said, which was, paraphrasing, it's easier for somebody who's been through it to relate to somebody going through it. And that completely makes sense to me. The flip side is true. Having not gone through it, I'm trying to get my head around. So it's easy. And so what can Sasha or Wesley or tell me about how heroin's different? What should I know about it?
So the first thing that came to my mind when you said that is that it's not just heroin and it's not just opiates, right? Every individual who comes in and provides a UA or tells you their story of what they use, it's not just that, right? It's also cocaine, it's methamphetamines, it's alcohol. It is, sometimes it's the lifestyle. The lifestyle is so attractive that's what it's hard to get out of.
Okay.
But I think that would be the one thing is to know that it's not just heroin, right? And it's not just the individual, it's the family, it's the friends. Like it takes a community to raise an individual, and it takes an individual who affected a community.
Okay, I've got people on with questions. Can we get to the 2 guys you brought to make sure that they have time, and then I have Mr. Dunbar and Mr. Weddleton.
Hi, my name is Jesse Diamond. I'm here to talk about the epidemic of opiates and other drugs and how they've impacted my life and the lives of people closest to me. I've been struggling with addiction since I was 15 years old, and drugs have been an epidemic in my life long before it's been recognized as an epidemic in the state or even in our country. I can speak from experience that the lifestyle that someone in the throes of addiction has to live is not a lifestyle that's conducive to being able to keep family bonds that are close, trusting, and loving. For me personally, my family immediately puts up boundaries, not because they don't love me, but to protect themselves from the behavior I exhibit and the destruction that I cause living a lifestyle of an active drug user. The closest relationships I have as a grandson, son, and a father of my children take an immediate backseat to the lifestyle I lead in my addiction. One of the main problems I faced living that lifestyle for so long was that I didn't know how to productively live my life any other way. So when I reached out for help, and my family members and friends had exhausted any ways of their understanding that they could help me, the people that were there to embrace me was the family at CITC Recovery Services. This was one of the first times that I learned that there was a solution to my problem, and the problem at that point in my life was more than just using opiates and other substances. It was living my life in general. During inpatient treatment at the Ernie Turner Center, I was taught in a therapeutic setting how to live my life. The classes taught me and helped me identify behaviors that I've exhibited for so long and gave me tools and solutions that I needed not only to change my behaviors, but to come to an understanding that I'm worth it as a person. One of the biggest encouraging factors in my treatment was having the opportunity to talk to peer support like Wesley over here, who could immediately relate to what I was going through. Being able to see someone that at one point was early in recovery like myself, but is still actively living a productive, happy lifestyle without using was encouraging in itself. But aside from just being able to see, I've had the opportunity to express my struggles and get firsthand experience on how they made it through similar situations. The structure of the recovery services that CITC offers gives me an opportunity to personalize my treatment to a life of recovery that is going to benefit me best. Rather than a lot of the other treatment facilities that offer services for a set period of time and graduate their clients, oftentimes without the necessary tools or having faced necessary personal issues that are vital to living a life of recovery. CITC was open to having me directly involved in my treatment plan. What that looks like for me is taking advantage of parenting classes at a program they have called Father's Journey. I've also embraced spirituality as a main part of my life this year and have implemented a faith-based recovery aspect to my treatment. So aside from educational classes, therapy, and the NA and AA meetings that I'm exposed to, I attend church and a faith-based recovery group every week. I found the key to my happiness and recovery is implementing activities in my daily life that I'm realistically going to continue to embrace when I leave. The recovery team at CITC has done everything they can do to listen to my needs, add their professional opinion, and help mold me back into a son, grandson, friend, and most of all, a father to my children. I'm currently enrolled at UAA and will be starting to attend college starting this spring semester. I found my own apartment and I'm able to show up every day to the best of my ability to my children. And none of this would have been possible without the separation from that lifestyle that I was living and the services that I received from CITC. So I want to take this time to personally thank everybody from CITC for helping me and thank everybody for listening and being a part of my recovery. And I know today that the best way I can pay anybody back is to instill everything that I've learned and help someone else the way I've been helped so they can envision a better life too. If there's anything I would like to be better from my perspective, it would be having more resources for individuals to be able to enter into detox in a faster manner, and somehow coming up with ways to educate and incorporate all the other friends and family members of those struggling with addiction so they can better be prepared to deal with and understand what one struggling with addiction is going through. The epidemic is definitely real, and from my point of view, everyone in this state has been touched by its reality in one form or another. Whether it be yourself, a relative, friend, or coworker, having the services to treat this epidemic and educate and support family members struggling with addiction is key to facing the problem head on. I also want to add that I also take advantage of medically assisted treatment. I'm on the Suboxone program, and I'll be on that for probably about 2 years. And I take this medication every day, and it has an opiate blocker so that even if I start to show relapse behavior signs, if I go and try to use heroin, I cannot get high.
Thank you. JC? Jesse, sorry. Sasha, we will have you back. If we could spend about 5 more minutes here, that'll leave 20 minutes each for the other two.
Can I say one thing?
Of course.
I apologize. I think that to answer your question about what do we do about this heroin epidemic that you asked, I think that it was discussed in Jesse's share, and as I'm sure it's going to be in other testimonies that are going to be done as well as our own, is that it's an individual, right? It's not the drug, but it's a person that we are helping, right? It's not a drug. So like Jesse had said, it's someone's father, it's someone's mother, someone's sister, someone's brother, someone's aunt, someone's uncle. Like it's a person who experiences substance use problems.
Mr. Dunbar, did you want
No, I'm fine. We have one more.
Yeah, then we do. And did you want to say something before that? Or
I have a question. I was filled in a little bit, but Sasha had said, the appeal of the lifestyle. And I'm going, the appeal of the lifestyle, what we just heard from Jesse, is this not very appealing? So what draws people back into this lifestyle that looks horrible?
Just being used to that way for so long, the fast money, the not having to be accountable for yourself. And those are all things that take a long time to learn. And for me personally, I have to have separation from that lifestyle along with treatment and peer support. And I take advantage of every tool I can. You know, so being on Suboxone, having been a drug user for so long, is another thing that I'm taking advantage of. I mean, it's really different for everybody. Some people are attracted to the lifestyle for the fast money because they have felonies or they have charges that they cannot see themselves succeeding and making money any other way rather than making fast money, where they choose to take that risk of living that lifestyle and going back to jail so that they can have that fast money and have what they think they need to be happy, which to an addict is drugs and money.
Just fast money because you're selling drugs? Not you, but people do. Okay.
Prostitution, drugs, burglary, robbery.
And then Suboxone, you don't go through withdrawals because it's a substitute and it doesn't allow you to get high from heroin, or does it?
You do go through
You do
withdrawals
withdrawals.
if you stop taking Suboxone.
Okay.
It's a 2 to 3 year program, and you're dropped slowly over time.
So it's a withdrawal of itself. You're weaning off of it.
Yeah, over
Okay.
time. But the goal is to, by that time, be living a different lifestyle
Okay.
to where it's not appealing to you.
And then I really do, if we could, we will have you back. So your final presenter is?
My name is James. I struggled with addiction to drugs since I was about 16 years old. And to kind of go off what he was saying, for me, I chose to do drugs to numb things that I had been through. I didn't want to deal with things in a responsible manner, so I masked it by using drugs. I've been in and out of treatment centers, and I never addressed those issues until now. I feel comfortable being able to talk to people who have been through the same thing that I've been with peer support. And it has been, unexplainably helpful to my recovery, being able to talk to someone who's been through the same things that I've been through and not feeling judged by someone that things that you're saying to them sound crazy. It's been, I love the treatment center that I'm at now. I'm a participant at Sean Luke. And before I went in, I was completely hopeless. I wanted to die. I lost all hope. Every time I got drugs, it was, I wanted to be over. I had given up completely. Every time I got drugs, I did all of it, and I was upset when I woke up the next morning that it wasn't over. I apologize. They're hard things for me to talk about, but I thank God every day that I made that choice to come into the program. I just wanted to go do my time so I could get back to the lifestyle I was living, so I could use drugs and just forget about the things that I've been through. And this place really gave me hope that I didn't have. Even when I came in, I was counting days to when I could just get out and ignore these feelings and these suppressed feelings that I had been feeling for so long. But I stopped counting days after a couple weeks. I realized I had stopped counting days, and the treatment was working, and I was addressing all these things that I had ignored for all these years, all these things that I just piled up and didn't want to look at. I was finally talking about them and coming up with solutions to live my life in a different way. I'm so thankful for everyone at Sean Luke. It's a miracle that I'm here today, alive, after the things that I've been through. I have a relationship with my family now. My mom, my dad is coming down to visit me in just a couple weeks, and I can't remember the last time I had a real conversation with my father, so that's a little nerve-wracking. But I'm blessed. It's a step in the right direction. I know I'm headed down a path that I have chosen not to take in the past.
Mr. Constant?
Yeah, thanks. Just something Mr. Diamond said or mentioned that I think bears reiterating and a little clarification. This notion of medication-assisted treatment, MAT as it's often called, a lot of people believe that the medication is the treatment, right? But it's not. The medication is an adjunct to the treatment process, that if you just substitute one drug for another, even one that causes symptoms to go away, it doesn't change the behaviors at the core of the problem. And so it's important for people to recognize that medication-assisted treatment is, the adjunct is the medication. They still need the behavioral health component to work over the next many months to make sure the change sticks. So thank you.
And thank you all. Sasha, Venus, Wesley, Jesse, and Jay. Apologize for the short time. We do an hour and a half, and it just goes too quickly, but it's really moving and informative presentation. So we will learn more and have you guys back. Thank you for all you do. Mr. Green, we'd love to have you up. You have a guest, Mr. Cameraman. We're agreed that you're going to train it on Mr. Green or us only. Great, I appreciate that. While he's coming up, Melinda took me to meet Ron. We spent somewhat of an afternoon at his clinic, the Narcotic Drug Treatment Center, or more colloquially, the Methadone Clinic. So I wonder if you could just, Ron, tell us a little bit about what you do, methadone's place in heroin treatment, and then you can introduce your guest.
Thank you. As Eric said, my name is Ron Green. I'm the clinical director at the Narcotic Drug Treatment Center downtown here on 4th Avenue. We've been there in existence since 1974. In fact, the clinic was started because of the heroin problem we were having in the city in 1974. So all we do is heroin and prescription pain pills. We have, our executive director's been there for 35 years. Our medical director just retired and moved to Arizona, but he was there for 34 years. I've been there 16 years as the clinical director. But
You're the newbie, huh? You're the new guy?
Right. Yeah. But and I have counselors, which is kind of odd for a nonprofit for people to stay as long. So I have 3 counselors that have been there 14 years. We have nurses that have been there 13, 14 years. So we have a lot of experience dealing with this opioid crisis. In fact, it's not a shock to us and surprise as to what's going on because and you can Google my name and put heroin next to it, and it will bring up all kind of articles that I did with the Anchorage Daily News, KTVA, and Channel 2, that we were sounding the alarm 13 years ago that there was a heroin problem coming this way. And we spoke to legislatures, we spoke to whoever we could. I kind of feel like the boy who cried wolf because they didn't heed the warning. And now we got another problem here with methamphetamine combined with the heroin. So just hold on to your seat because you will foresee more things coming. I also predicted 13 years ago that you would see a spike in crime because this is what the people were telling us when they come in. How do you get your money? Prostitution, burglary, whatever I got to do to get my money, I'm going to get it. And what they're afraid of is the withdrawals, or they call it being dope sick. So it's going through the withdrawals. They'll do just about anything they can to get their fix. And so we treat them with methadone. So there are 3 approved medications, and Chris mentioned it, medication-assisted treatment. There's Suboxone, what Jesse mentioned, and that's buprenorphine is the same thing. And then you have Vivitrol, which is an injection that a person would take once a month. And of course the methadone, which has been in use in this, in 1947 it was introduced in this country, but it's been used in treatment since the early 60s. And so our clinic's been in existence coming up on our 44th year, and again, that's all we do. We were shocked, and I must say I felt offended that when the state put this opioid task force together, that they didn't include the Center for Drug Problems or the Narcotic Drug Treatment Center. We're the experts on this topic, and so we didn't understand why we were shunned. But they told us that they had the clinic from Fairbanks, and that was fine. It's a much smaller clinic. So there are 4 clinics in the town right now, not in the town, but in the state. And at the time, there were only, 13 years ago, there were only 2 clinics in the state. The Fairbanks Clinic, which they had 41 patients, in our clinic, which we had 75, but then working with Senator Johnny Ellis, we were able to get some additional funding. And so we were up to 100. Now we just received a federal grant. The state of Alaska did $800,000. We get $450,000 of that every year for the next 2 years, and the other $350,000 goes to a program up in Juneau. But we also get a grant from the Division of Behavioral Health, a little over $1 million a year, and that's the great thing was with Medicaid expansion, because our program was 90% women. And so we're different from any methadone clinic in the world. Everybody else is.
Well, that exact point was a big surprise to me. I've been thinking about it ever since. Why do we have the only methadone clinic that is mostly women that you know of?
Nobody's ever been able to answer that question. I think because we prioritize pregnant women, and in my 16 years, we medicated over 600 pregnant women in our time. So they get priority admit. And the problem was, though, these women have significant others that they go back home to. And so if they're not clean, the woman has to know he's in the bathroom or she's in the bathroom, and they know what they're doing. So it's not a good scenario to get people clean and to do that.
And just so we're all on the base level, what does methadone do? Is it an intoxicant? What's its function?
Methadone is a Schedule II narcotic. What it does is, and what they were speaking about earlier is, when people start to take narcotics like heroin and prescription pain pills, and I forgot to say, the majority of people that take prescription pills do so responsibly. But there's just a segment in our society that they take these pills and they love how it makes them feel, and then they become dependent on it and then addicted. And that's when we see them, when they become addicted. In fact, you can't be on a methadone clinic unless you have at least 1 year history of opiate dependence, and they do that by providing us with notarized letters from family members and friends that will say, yes, this person has been addicted for years. But methadone helps them to feel normal. And so methadone is also a pain medication, but only the methadone clinics that are federally recognized can prescribe liquid methadone. So if there's liquid methadone being sold on the street, then it's coming from one of the methadone clinics. There's no other place you can get liquid methadone. The pain management clinics use pills. Methadone gets a bad rap. I understand that because in the 70s, when they opened up methadone clinics, they were for-profits, and they were charging people 20 to 30 times the amount of what that medication was worth, and it should have been 50 cents on the dollar. And they cut out all counseling, and they were referred to as juice bars. And this clinic was no different than when it first started. And so now we're structured, we're regulated, we answer to SAMHSA, we answer to the Drug Enforcement Administration, we answer to the Division of Behavioral Health. The DEA walks in anytime they want, flash their badges, open up that safe. Every drop of that methadone has to be accounted for.
Okay, I don't want to use our time and have some questions here. So I can drive when I'm on methadone?
Absolutely.
I can go work, I can do all that stuff?
If you're on a therapeutic dose, and that's our goal, is to get people stabilized. And we expect that people are going to continue to use until we get them at a therapeutic dose. And once they get there, they can use all they want. Methadone will block that out. It will block out all opiates. We're seeing a lot of speedballing now. It used to be with cocaine and heroin. Now it's methamphetamine and heroin. And methadone won't help with the methamphetamine. So we need to get people into inpatient treatment. But a lot of people won't accept our patients because they don't see people on a dose of methadone as being in recovery. And we do. So as long as when we test them, all that's in their system is methadone and the metabolite of methadone, then we consider them clean. If they have any other drug, then of course they're using, and we address that.
And it's still a success, in your opinion, if they stay off any other drugs, keep their job and their kids, and stay on methadone for the rest of their life.
Absolutely, absolutely. And some of our people on the program, we've had people on the program that our longest patient passed away last year. He'd been on the program since 1985. But we got people that have been 5, 10, 15. We got people 27 years. I don't think those individuals will ever get off But some of the younger people we got coming on, now that we have drugs like Vivitrol and Suboxone, I hope at some point that they do taper off and to get on another medication, because again, methadone is very restrictive. They have to come to the clinic 7 days a week. We're open on holidays, we never close. And so they have to come and get that medication until they can prove to us under the 8 guidelines of the federal regulations that they're not involved in crime, that their home environment is safe. We go to their homes, we check their doors, we got to put deadbolts on, we want to know where you're going to store this medication. You've got children, we want to make sure you keep it out of the reach of children, and they have to keep it in a safe or a lockbox.
Great. I have a number of questions. Mr. Trainey.
Is the methadone you supply to people liquid or pills or?
We supply liquid methadone.
Liquid, okay.
The methadone clinics, that's all they use.
They have to take it every day?
Absolutely, every day.
Thank you.
Mr. Dunbar.
Thank you. So you said something interesting. You said the majority of prescription pain users don't abuse. I'd say in the same way, a majority of alcohol users don't abuse. They maybe have a glass or two. But we know that the heavy users of alcohol cause a lot of societal problems, and so we heavily tax alcohol and use that to pay for treatment of the things. Well,
We're working on
let me finish.
We're working on that, sir.
So here's my question. Should we tax prescription opiates and use the funds to pay for treatment?
I would love that, but I don't know that that's even been discussed.
Mr. Constant.
Yeah, thanks. You mentioned that you have a DBH grant to the tune of $1 million. What do they fund?
What do they fund?
Yeah.
Well, they fund the whole treatment. So it's the medication, the medical director, the nurses. Primarily, that's what it pays for. Methadone, you know, I've seen statistics where to incarcerate somebody a year, it's pretty close to $60,000, where in a methadone clinic, we can treat somebody for about $7,000 a year per patient. And so Medicaid, most of our people are on Medicaid now, but...
So how long has that funding been in place, and how...
Well, it's been in place since I've been there, since 2002.
Okay.
So I'm sure it was in place before then. And for a while, the state flat funded everybody. For 15 years, there were no increases.
Right.
So problems were getting bigger, and they were saying, you need to learn to do more with less.
Right.
It was what we constantly heard. And it was kind of impossible. At one point, we shut our doors for 4 months. We didn't admit anybody, including pregnant women. And so that was at the height of when we started seeing this heroin problem getting worse. And I was comparing it with the state troopers' drug, where they pick up drugs. And 12 years ago, it was a gram or here or two. And then we started seeing ounces. And now we're seeing kilos coming up everywhere. So it's certainly a problem, and it's going to get a whole lot worse before it gets better.
Last point, and that is, I think you're uniquely positioned to answer Mr. Dyson's question about kind of what the addictive process is, how an individual goes through that. What is that?
So a person takes a medication, and I went through a stint where I got dependent on my pain medication for the 12 surgeries I had in 11 years. But a person takes this medication, and it tricks the brain, and it has to do with dopamine. So I'm not a physician, and I don't want to get out of my realm, but their brain changes. And Dr. Volkow from NIDA, she says that a person may want to stop, but it's like driving a car without brakes. You may want to stop, but you can't do it. Your brain has changed. And so methadone or Suboxone or Vivitrol, you give it to a person, and it helps them to feel normal so that they can then go to work, pay their taxes, take care of their kids. That's what it does. And so, and their brains will change forever. Some of them never get back to the state that they were in prior to abusing or becoming addicted. But there is a big difference, and one of the things that I wanted to clarify was there is no such thing as babies being born addicted to opioids. Babies are born dependent on that opioid that their parents or that their mom took during the pregnancy, and they can be weaned off. And so I've been there 16 years, so I've seen kids that are 16, 17 years old now.
You're making the distinction between dependency, chemical dependency, and addiction. Just in a sentence or two, what is that distinction?
Addiction, the DSM-5 describes it as you've got to meet certain criteria. And so dependent, if you take your medication as prescribed, so they give you pain pills, they take 2 pills every 4 to 6 hours, you're dependent on that medication to deal with your pain. When it becomes addiction is when you take a 90-day supply and use it up in 10 days, and now you're doctor shopping, or you're out on the street, or you start to intravenously use it. Those are signs of addiction.
Great. And conscious of time, I have Mr. Dyson and Mr. Weddleton, and we want to get to your guest, of course. Mr. Dyson.
I appreciate what you do, and you've been doing it for a long time, and to make it a priority of pregnant women. I appreciate that. I'm always interested in what causes things. So, law enforcement people we have around here have said that drug use and crimes that come from it have started increasing 2.5 years ago or so, and almost reaching a vertical asymptote here. You got any sense of what was going on 2 or 3 years ago that caused or precipitated what we're experiencing?
Yeah, what was going on 2-3 years ago was the same thing that was going on 13 years ago, was that heroin, there's a book out, let's see if I can remember the name. It'll break it down for you entirely. Dreamland. If you read that book, Dreamland, it'll give you the whole kit and caboodle of how Walmarts and pharmacies and Medicaid and how this Mexican cartel took heroin and turned it into a pizza delivery. And we had it here in Anchorage. And they would, all you had to do was call up a dealer, so and they would bring it to you.
The cause was there was more supply that's easier to get to?
Well, the cause was the feds started coming down on these Dr. Feelgoods that were prescribing massive amounts of medication. And I forgot to say that, we make up 4.6% of the world's population, but this country consumes 83% of the world's opiates. Okay. So that's a problem.
Yeah, so the problem wasn't that there was people who needed it emotionally or socially. The problem was that there was just so much more supply.
Well, it was that and the fact that people were cut off after the feds came down from their doctor. And so somebody would say, well, I know how you can get better.
Then the logic of your argument, if the person hadn't been the patient of a doctor, we wouldn't have this drug epidemic we got?
My logic is that prescription pain pills is the stepping stone to heroin.
I got that. But all the people who are doing drugs here and so on that didn't start with the opiates because of pain, they got them on the street or wherever else. What caused them?
As the previous guest spoke, was the lifestyle. It was associating with other known users or stealing dying grandma's pain pills. And there was mentioned earlier, and I know of 10 years ago at Service High School, a nurse reported to us that kids they called them Skittle parties. They would steal pills from their parents or grandparents, throw it in a bowl. It wasn't just pain pills, whatever. And just take it and chase it with milk. So that's been going on for a while.
Thank you.
Mr. Weddleton?
Well, Fred touched on some of it, but I guess I'll reposition it a bit. Is we've heard repeatedly 4 out of 5 addicts started with prescription drugs. So if we and now we're restraining doctors and they're not prescribing so much, so we should be over the hump and things will be all better in 5 years, right?
That's nice. That's a nice thought. That's not going to happen.
Right. Okay, let's get to your guest if we can, because I really appreciate you setting it up.
So I just want to introduce. We won't say her name. I'll just have her tell her story.
Hello, I'm a heroin addict in recovery. I came from a loving 2-parent household. My dad was in the military, and my mother was a stay-at-home mom. In high school, I experimented with marijuana and alcohol here and there. At 16, I became pregnant with my beautiful daughter. I was becoming a bit rebellious at that age, and after I found out about my pregnancy, I changed that so I could graduate on time and be able to provide for my daughter. At 18, I started dating someone, and he introduced me to Oxycontin. I got hooked on the Oxys, and we began to steal to support our habit. Eventually, I got arrested for burglary and was charged with felony theft in the 2nd degree. I was put on probation, SIS, for 3 years. Unfortunately, I was not able to complete that as I continued to use and had dirty ways and violated the probation many times. Eventually, I flat-timed my sentence and did 7 months at Highland Correctional Center. After release, I did not use until I met someone at work who was also an opiate addict, and he was prescribed methadone pills for pain. He would give them to me, and then I was right back to using oxys again. I was also introduced to methamphetamine and started smoking and snorting that as well. Eventually, I started shooting heroin every day and was stealing from my parents even just to support my habit and not go through the terrible withdrawals. I would steal, lie, and use others just to get some heroin to feel well. I was so sick and tired of living this way, I called CDP for help as I realized I cannot quit on my own and I needed help. I called only to hear that there was about a 6-month waiting list. My heart dropped. What was I to do? I had to continue using until I finally got my intake date 4 months later. And I was so grateful. I attended groups and was assigned a counselor. Life got much better in every way. After a few years, I started tapering down slowly. When I got to 0, I graduated successfully. Unfortunately, a few months after that, I ran into an old friend and started hanging out. I didn't know at first he had also been addicted to heroin. We eventually started using again together, and I was back where I was years ago, before I was accepted into treatment at CDP. And during that time, I had lost my job. I contracted hepatitis C. But at CDP, if you graduate successfully, you are allowed priority to readmit into treatment. I called and was able to get back into treatment at CDP. I started attending groups again and seeing my counselor regularly. I got stabilized on my dose of methadone, and my life slowly started getting back to where I wanted it to be. I began mending relationships, getting healthy, got a new job, and set goals for myself. I started working with DVR and started taking classes at UAA. And unfortunately, during that time, my dad passed away, and I'm so thankful that I was able to be in treatment for him to see me do well, and so that I could be clean and actually spend real time with him. I'm doing well, and I'm happy and healthy. I do plan on tapering off methadone at some time when I'm ready. And I am seeing the effects of heroin abuse around Alaska getting a lot worse. It saddens me very much. I would like to see more resources for people that want to receive help.
Questions for Ron's guest?
I do have one.
Mr. Constant?
Yeah, you know, I heard that the clinic delivers, thank you for your story first. Thank you. The clinic delivers liquid methadone. How do you deliver it?
No, we
Is it injected? Is it oral?
It's dispensed. They come to the window and the nurse dispenses it. But we also have people, and I'm not sure if she is one of them at this time, but we have people that we only see once a month. They've earned carryouts.
Right.
They've met the federal regulations. They take their methadone home, they store it, and they dose themselves every
So
day.
it's oral.
And we have a callback, so we'll, diversion program, we'll call them back, and they come back if they're supposed to have 22 unopened, untapped bottles should not be tampered with, and then they can keep them. If there's anything out of order, they'll lose that privilege, and then they'll have to come in every day and dose.
Thank you.
Ron, do you let people back on when they lapse? What's the procedure? I mean, I've heard, and her story was, it may take a couple of times, right?
Yeah.
So what's your procedure?
We never shut the door on people. Sometimes they may have to wait 30 days, but as she said, she waited 4 months. We had people waiting 2 years ago because there were only 2 methadone clinics in the state. But now we're getting people in 3 times a week now, and so there's no waiting list like it used to be.
The wait list isn't just low; it's eliminated. You get people in.
It's pretty much eliminated.
Pretty much.
Yeah. People have intake dates now. They know when they're coming in. Where she had to call once a week and call me once a week just to keep her name on the wait list.
Other questions, Mr. Peterson?
Thank you, Mr. Chairman. So you're taking in all clients, not just pregnant women?
We're taking everybody, and everybody is qualifying for Medicaid these days, so that has helped tremendously.
Thank you.
Okay. Just if you would, Ron, address sort of the criticism that there is of methadone clinics, that you're keeping people on a drug sometimes for extended period of time, theoretically forever if they want. Why is that an appropriate thing?
Well, because we see it as I'm a diabetic and I also have high blood pressure and I take medication every day to control those conditions. That's how we see methadone. It helps them feel normal, and for some individuals they're going to need to take it for the rest of their lives, especially the people that are in their 50s and 60s and have been on the program for a year. I don't see them getting off this medication. But for the younger people, it's my hope, although we don't discuss it with them. She says she wants to taper off at some time, we will help her do that. But if they say they want to stay on it, it's between the patient and our medical director. It's nobody else's business how long they stay on a methadone program.
You don't want to apply that pressure because you're worried that...
Well, they get enough pressure. I mean, people are stigmatized being on a methadone clinic. And not only from family members and friends, but from other professionals. There are treatment facilities in this town that won't accept our patients. We need to get a woman in treatment. Dina Coy has been the one-person program, and Ernie Turner on occasion, and now Akila has finally decided to get on board. But for a while, we had problems with people accepting our people into our programs because they're on a dose of methadone and they're nodding out. Well, if you see a person nodding out, then their dose is too much, and we watch for that. So they shouldn't be nodding out. It should make them feel normal to where they can operate heavy machinery, drive a vehicle, drive city buses. We've got people in different vocations around town that they don't want people to know that they're on a methadone program because they could lose their job.
Ron, I'd like to thank you both for what you do and for coming here today. And ma'am, thank you for telling your story. It was very moving.
Thank you for having us. I'm going to leave some information here with Melinda, some recommendations for state and federal information and medication-assisted treatment, opioid myths and facts.
Good. She can scan those and get it to all of us.
Thank you for having us.
And then Kathleen McLaughlin. Hi, Kathleen. You saw me trying to move things along. I apologize that we left you with about 10 to 15 minutes.
I'm a fast talker.
All right.
Thank you. My name is Kathleen McLaughlin. I'm the director of the Partners Reentry Center down on 4th and Barrel. We were funded starting about 4 years ago with state funds. The intent was to reduce recidivism and enhance public safety. Our average, because of SB 91, SB 54, the opioid crisis, and the homeless issue, we used to serve 56 people a day. Now we serve about 100 people a day, unique individuals. We have a staff of 8 people. Our goal is really simple. We are not medical providers or clinicians. We're simply people that case manage very short term for people that are coming out of incarceration, and also try to getting them referred into appropriate programs. Our key is housing, because we believe that unless you have a safe, sober place to live, the chances of you being successful is going to go down. Right now, we have, as of November, I just pulled statistics for this, we housed 183 people in the month of November. That money came from the Criminal Justice Reinvestment Funds. $250,000 was received by partners. We also had $550 of state monies, and we also have some HFC and a little bit of federal money through a SNAP program. The goal for us is to get people hooked up into what they need. We find that about 80% of our participants, and we have about 437 people in our program right now, have a substance abuse, mental health, or a combination of both of those challenges. About 3 years ago, in September of 2015, we started what we called the Vivitrol program, which we're kind of the third leg of what we're talking about with medically assisted treatment. We had a guy came out, he was 24 years old, spent 2 years incarcerated for a drug charge. He came in on a Monday morning, and he said, I'm so proud of myself. I got a job, you're housing me, and I'm proud that my parents are going to be able to say he's on the right track. That night he was dead from a heroin overdose. And what happened was he took the same level of heroin after he ran into his buddies that he took 2 years before he was incarcerated, and he was clean within the system. That struck me. I don't have a medical degree. I don't know anything about a lot of medical stuff, but what I knew is that kid, that young man, deserved a chance. So we started the Vivitrol program, and basically it's a shot in the bum every 28 days. It stops the hankering for opioids and alcohol. So the trick that we did was, as soon as someone left incarceration, we housed them that morning through Medicaid. We would get them a provisional letter, and they would be taxied over to my health clinic and get the shot that night. And so we knew that the first 7 days of release from incarceration were the trickiest for people, and so we wanted to hook people up as quick as we could. We have now, with the Department of Corrections, started the Vivitrol program behind the walls, so that if individuals are fearful that they will start using the moment that they get out the gate, that they can take their first shot inside, and then we try to pick them up after they release. We've had promising statistics. I'm just going to do this real quickly. I got 4 more minutes. We have 275 people since then that were offered Vivitrol. 149 said, yeah, we'll take it. 126 said, nope, we're going to do it on our own. Of the 149, 64% have not recidivated. They're still housed and in employment in the state of Alaska, and 36 have recidivated. 36% have recidivated. Of those that declined it and said, no, I'm going to do it my own way, 21% remain in the community, and 77% have recidivated, and 6 have died of heroin overdoses. So I'm not here to plug Vivitrol, because I agree with everyone else that the medicine isn't the answer. The only thing Vivitrol does is it calms the mind so that you can start working on the behavioral issues that are underlying the behavior, or the reasons why people use. Yesterday I did an intake. The woman's 43 years old. She has 6 kids. She got hooked on heroin. She's graduating from Nugent's Ranch, and she's going to come in and join our program now. But she's on her 5th Vivitrol shot. And she wants to keep doing it because it gives her a certain base. But what she told me, which I thought was really interesting, I said, well, you lost your 6 kids, you lost your home, you lost your family connections. What happened? And she said, well, I knew a pain doctor in this town who gave me 450 pills a month. I got addicted. And when I said, now I'm addicted because I have 450 pills from you every month, and that pain clinic said, we don't treat addiction. So you go figure out what you're going to do. My point being, there is no simple solution to this. We see this every single day, especially now that we're putting a lot of homeless people, because of the overflow issues, into our system. If they have a criminal record, we're housing them that night that they come in, just to help in that area. There isn't a simple solution, but if we don't recognize that behaviors are caused a lot by trauma, by things that have happened, and if we don't get down to getting people accountable and transparent with their own lives, no medically assisted treatment is going to solve it. So that's my pitch. And
nicely done. And we'd like to have you back too. Very, very briefly, I have a couple other questions. The difference between how they work, or whatever significant difference between methadone, Vivitrol, and Suboxone is?
Vivitrol is a sensory blocker, so it blocks so that you cannot get the pleasure of using opioids or alcohol.
Roger.
It will not stop it from methadone, or from meth. You can still get high on meth. Suboxone and methadone are I hate to say the word substitutes because it's not substitutes, but they have an addiction component, whereas Vivitrol is focused on abstinence. It's focused on not using any opioids or alcohol because you just don't get the pleasure. You can take Vivitrol every 28 days for as long as you want to because it's not addictive. And one of our weaknesses is some people will only take the first 30 days of it, one shot, so that everybody will say that person's working on their addiction. And then on the 31st day, they're already planning getting high. So the intent behind each one of these medications is how is that person going to use it? We have people in our program, by the way, that are on Suboxone successfully, on methadone successfully, and on Vivitrol successfully. But
not it's or, but the others that are.
Right.
Yeah, never. You never double them up. You know.
Yeah, you can't. Vivitrol, you have to be clean to get the shot because it will put you in automatic withdrawal.
Okay. And Ron, you want to add anything to that, or is that a fair description?
That's absolutely correct.
Okay,
and
good.
That's part of the problem is a lot of addicts can't go 7 or 10 days in order to get the Vivitrol, and so you have to be clean, like she says, that amount of time, because it will put you in immediate withdrawal.
Good. I have Mr. Dyson, Mr. Constant, Mr. Train. Mr. Dyson.
Yeah, I appreciate what you're doing. If I heard you correctly, you said a bunch of the people that come to you have just gotten out of jail?
Correct.
Yeah, so as a result of SB 91, nobody's been sentenced has been getting out of jail. You know,
Nobody's what?
who has been sentenced is getting out of jail because of SB 91. There was no component in there that changed what was already sentenced. You know, there's some going back and looking at that. So SB 91 hasn't caused people to be who have been sentenced getting out of jail. And SB 54 just became the law. So where did you get the idea that SB 91 was causing that problem?
I don't think it's a problem. I think that our numbers have gone up as a result of SB 91 and 40 and 54. And the reason why is that embedded in SB 91 was some, for lack of a better term, diversion opportunities so that people are doing behavioral contracts, they're staying out on probation or parole longer, they're not being kicked back for short periods of time.
Okay, so they didn't get out of jail, they had a diversion.
There's diversions, there's a lot of things that have happened. The other thing that's happened is people are getting out on sentence served because we had such a large number of people that were unsentenced that were at Anchorage jail. And then as soon as there was the realization that they had overspent their time, they were getting released immediately.
Right. Thank you.
Right.
Yeah, didn't agree with the premise. Mr. Constant.
You know, it's funny you should hit on SB 91 because I was going there too. The one good thing that I've seen DOC do in this process of their transition into this new model is that they actually, the one thing they invested in was the MAT inside the jails. And so of all the new services, they're finally getting up to speed with their delivery after months and months of not. But the one thing that it appears they've done right is the MAT, which helps you to do your job.
Right. And I'm an advocate for SB 91 and 54. I think criminal justice reform is very, very important. So I don't want my comments to suggest that I'm against it. I'm the boots on the ground. And so we have had to learn just how to adjust to the expectations that are in that law. But I totally support it.
Yeah. What keyed me is when you said these people can't do it when they got out. You know, that led me down a little bit of a wrong track.
Yeah, sorry about that.
Mr. Trainee?
How much money did you receive this year from the state for this program?
This year our budget was $800,000. $550 of that came through a contract with DBH, and another $250 came from the Criminal Justice Reinvestment Funds. We also received Alaska Housing and Finance under the Homeless Assistance Program, about $150,000 there as well.
Thank you, ma'am.
What's DBH stand for?
Department of Health and Social Services, the Department of Behavioral Health.
Behavioral Health.
Division.
Division, there we go.
Thank you. We'll have you back for the committee. Yes, Mr. Steele?
Yeah, I was just wondering how much of the homeless population do you think has a problem in terms of...
With addiction?
Yeah.
Well, I can tell you that 1 month ago, we were concerned about the overflows, so we took people on 40 new people from the street into our program. 36 of them had active substance abuse issues. So it was pretty high. What we found is that a lot of self-medication is because of the hopelessness that they come in with.
Makes sense. What would the committee like to see as a follow-up to this? That is, this was meant to be introductory, but what do you want to know next? And just as a preview, January 3rd, we're switching gears back to felony prosecution and what the state's doing or not doing and whether we should step in. But the January 3rd, and then January 17th, the second meeting of that month of this committee, will be back on this issue. Ms. LaFrance and I have been working on the prevention or starting issue, that is the opiate issue, how kids might be getting on, how prescriptions affected this, and what we might do to prevent it. But what do you guys want and gals want to know more about? Mr. Dyson.
So this was more valuable than I thought.
Yeah, thank you, man.
Well, that makes my day.
Do you have low expectations or something?
Yeah, so I think I would like to get the law enforcement folks here, and the chief told me that there's a captain there, and it may be that they will come back to us and say this person who's working it from the APD's perspective can tell us all in an open meeting system. They may recommend that we go into an executive session for a bit of inside stuff that they may not want out on the street. And maybe we'll just skip that. But
no, it's interesting. Okay. And you've gotten me before, but you'll give me that captain's name and I'll follow up there.
Yeah, Eric, I'd like to see some of the school district here. I don't care if it has to be executive session or not. But the kids are getting hooked at the 14, 15, 16-year-old level. By the time they need to be 17, 18-year-olds on their own, they're already addicted. So I want to know what the school district's doing. And we'll probably have to have an executive session for them to tell us what steps they're taking to stop this from happening.
Can I just jump in really quick because we're out of time? Just two things. First of all, the state has bags available, many of you know, for disposal of prescription drugs. I have some of those available. But to Mr. Trainey's point, I wanted to mention that there's a community cafe scheduled on the south side of town, specifically to look at this issue. Many of us, as parents, are aware of the Skittle pill parties and proliferation of prescription drugs.
And they don't care what they take. They just throw them all in the bowl.
Right.
Take a handful and have fun.
So just February 8th at Golden View Middle School from 6 to 8 p.m. we will be having a community discussion to look at this issue and especially to what Mr. Trainey is talking about and some possible responses.
Okay, and you guys can get back to me offline. Mr. Constant.
I would like us to invite both the Commissioner of Corrections, the Commissioner of Health, to come with and have a conversation with us about vision for the future and how we can collaborate at a high executive level. And I would also like to see the Commissioner of Corrections' new pre-sentencing officer leadership team come here, because they're just, as of the first of the year, going to start deploying a whole new team of like 40 officers to begin a new whole array of services that don't yet exist in our community to target the people coming or going into the institutions. So.
Good feedback. The state's drug czar is Andy Jones, not czar, but anyway. So that was on the list to do. Yeah.
And well, from the information we got today, somehow we've got to figure out a way to keep heroin and meth and other drugs out of our prisons, because when they're locked up, that is a chance for them to get clean and sober. But if there's more in there than there was outside, then it just exasperates the whole thing. You know, it makes it worse. I don't know how to stop that, but it's obviously a problem.
I'm sure it's not intentional, but an inmate going through withdrawals may be a lot harder to manage than an inmate who's being maintained. I've got to go now because we have the other. Thank you, Ron. Thank you, Kathleen. Really, really thank you, Melinda. The CITC left, but I'll thank them offline. And this meeting is adjourned.